Hello and welcome to HIPAA compliance training. My name is Clayton Radakovich. I am the Director of Compliance and Risk Management at Memorial Hospital, Sweetwater County. We're going to go ahead and get right into this. Why is this training important? So it does outline ways to prevent accidental and intentional misuse. It actually is an easy way to make it secure by training staff to limit the number one risk of disclosure, but it really is just about doing the right thing for our patients. We want them to feel that their information is as private and secure as we can make it here at MHSC. And that should be what drives most of what we do. First, we must look at what protected health information, or PHI, actually is, and you'll see PHI through the remainder of the presentation. And it is any individually identifiable information that has to do with patients in any way, shape, or form, and it can be things that we either create or receive or transmit in any way, and it can be in any form: paper, electronic, or verbal communications. So just sitting and having a conversation inside of the hallway and mentioning a patient name and having someone walk by and hear that patient name is enough to constitute a disclosure. HIPAA itself was created in 1996 by the Congress at that time, and it was finalized. The original law was finalized in 2006 finally, and then HITECH came out in 2008 that further adjusted some of the pieces for the security of health information for electronic health records. And it is overseen by the Department of Health and Human Services and enforced by the Office of Civil Rights of that department. Under Department of Health and Human Services, there are many offices. Like every public health office in the states and local public health are under Department of Health and Human Services. CMS is under Department of Health and Human Services, and the Office of Inspector General. And it created regulations on the privacy of health information. Basically everything that's inside of this presentation, you'll see the security of health information, which it dictates what we do with our various systems, health related or not. The notification of breaches of confidentiality. So if we have a breach, we have to notify the Office of Civil Rights and the patient, and the penalties for violating that. And then the training for staff. So you're going through this training because of the HIPAA law itself. The overall summary of the law itself is to establish basic privacy and security protection, which we discussed, but it's also to guarantee that individuals have the right to access their information, and they actually own the information. Before HIPAA, the facilities in which these patients received care own the information, and now with HIPAA, the ownership is clearly with the patients themselves, and then it does simplify payment for healthcare, the transmission for payment for healthcare. On this slide, you can see some examples of PHI, and there should be no surprises on this list because all of this information would have patient's name, date of birth, that type of thing. And we actually have a special name for those type of identifiers. They are called direct identifiers, and you can see on this list there are individuals' names, social security numbers, driver's license numbers, that type of information. But there are indirect identifiers as well that by themselves can make some information individually identifiable, and then it becomes protected health information. And on this slide, you can see a handful of these examples of these, and you see that there are some things on here that may not by themselves have been PHI, like street addresses or telephone numbers by themselves, but if you add enough of them together and it can be individually identifiable, then it does still constitute protected health information. When we look at who is subject to HIPAA, at our facility, it's anyone that's providing a service in MHSC or for MHSC that operates within or around any of our buildings. And this would include our employees, our providers, our volunteers, any vendors that we have in the building, contractors if somebody's doing construction, but also our community partners like Southwest Counseling or the coroner's office. And all of these for the remainder of the presentation are just considered staff. As far as HIPAA is concerned, these are all members of staff. And HIPAA itself protects PHI by limiting who may use or disclose it and who may access it, really, in general. And then we get to say what the purposes are for which we disclose PHI. And then it requires the use of safeguards on how PHI is used, stored, and disclosed. And those safeguards can be in our EMRs, where we do a role-based restriction. So based on your job description, you have so much access to information. If you're in the lab, you don't have access to nursing, and vice versa. And then we also have physical safeguards where we have badge access or keyed access to everywhere that has a large clearinghouse of HIPAA, basically in health information management or medical records, something like that. where the layperson or the normal person that doesn't work in that department wouldn't have access directly to that warehouse of information. And then it does limit the amount of information that may be used or disclosed for each time, and they call that the minimum necessary rule. The minimum necessary rule tells us that we should be transmitting only enough information and only that amount of information that we need to get our purpose across. We can accomplish our purpose. And this does not apply for the treatment disclosure rule, which discuss here in just a few slides. But this would be something like we're trying to send something to insurance for building. We wouldn't send the entire hospital stay for that. Unless they requested more information, we could submit it at that point. But for original claims information, we're only going to send that claim. And this would also be if you requested lab results from last week, we wouldn't want to send the lab results and every hospital stay they've had since 1989, just because we're complying with that request. So the general rule for how PHI may be used is that it may only be disclosed for permitted uses without an individual's specific written authorization. And that last part about the statement is really the important part. If a patient gives you written authorization to pile up all of their records and throw them into the parking lot and let them go flying, if that's what the patient would like us to do with their information, we can do that as long as they give us specific written authorization to do so. So without a release, though, our permitted uses usually fall within the three main categories: the TPO, the treatment, payment, and healthcare operations. There are specific public policy exceptions, though. If we have someone that tests positive for an infectious disease, and we are required to report that to the state lab or public health, and so we can do that without any sort of violation of HIPAA. If we're complying with law enforcement in any way, shape, or form, either via subpoena or abuse and neglect information, that type of thing, that is also an exception. Any other use requires that written authorization. Treatment is fairly self-explanatory. It's everything that goes into treating the patient for what they've come into our facility for. And this can be transmitting or accepting information, health information from another facility. It can be any of that documentation. And again, this is the only disclosure not required to meet the minimum necessary rule. So if you feel like as a provider you have to get the point across by sending the lab results, the imaging film, and an entire hospital stay, you can do that to establish that continuum of care. Payment is, again, fairly self-explanatory. It's anything that goes into payment and obtaining reimbursement for their health care. So that could be medical necessity, billing, eligibility determination, any of those things. And it can go to insurance, Medicare, any of that type of organization. Healthcare operations is the third main disclosure without written authorization. And this goes into any activity used to improve the business process of the hospital or organization. And that includes credentialing, auditing, utilization review, quality assessment, training programs, case management, any of those. And this is where our computer system support would fit in as well. The only thing that doesn't fall into this, does not apply to this, is marketing. So you could not take a picture of a patient's face and then use it to market a campaign in your facility without specific written authorization of the patient. So I discussed a little bit about the safeguarding PHI from the physical and the electronic perspective, but there's a lot of things that you can do specifically to safeguard information. And patients consider this information some of their most confidential information. So we have to be that much better at safeguarding the information that we have. And so what you can do, honestly, is just, if you don't need to have access to it, don't access to it. If you have access to it and you have the information, just don't discuss it with those people that don't need to know, and then don't provide it to anyone who doesn't authorize it. So it really is just don't talk about it. If you end up getting it, the easy way to make sure there's not a disclosure is to not discuss it with people. And when using PHI, we have to think about where we are, who might overhear, and who might see. And this counts for things that we would do in our normal work. I was telling a story during training about a nurse who was going between rooms and forgot to tell the patient a seemingly important piece of information. And on the exit of the room, this nurse turned around and said, "Oh, and your chlamydia test came back positive," and then went into the next room. But the nurse was close enough to the hallway that the people in the hallway and the nurse's station and the patient in the next room could hear her telling this patient that the patient had a positive chlamydia test. So the patient didn't complain, oddly enough, but the patient in the next room did, and said that if it was her chlamydia test, she wouldn't want it yelled out by the nurse's station where everyone can hear. So that was a normal work function, but still there was a disclosure there. Continuing on with ways to safeguard PHI, just remember, do not discuss it in front of others who do not need to know. That came up earlier. If you have a workstation, this happens a lot at nursing stations. Make sure that the records aren't up and accessible for people who are just walking by. And then again, with the monitors, if the monitors are faced in such a way where people can walk by and see patient information, we want to try and position those to minimize that view. And if you get up, you can lock your computer and make sure that those can't be accessed while you're not sitting at that computer. And refrain from using printers located in public or unsecured areas. And this can be a problem if we have network printers that we're printing to, we don't know the location. Just don't print to those printers. Only print to printers that you know the location and you know where that information is going to come out. We want to make sure that we follow our safe practices for our computer system ID and password. And right now we're updating our passwords every 90 days into our domain, which is required by our HIPAA security rules. So we want to make sure that those are strong passwords. One of the easiest ways that people are getting into facilities and hacking into their information is by figuring out poor passwords, pretty much. And we want to make sure that those are kept confidential and secure. I would like you to not write them down, but if you have to, just make sure that you have it someplace that's very safe. You're not going to lose it like a wallet or purse or something like that. And don't let anyone access the computer system under your ID or password. As far as this slide is concerned, we only want to access PHI from workstations that are approved by IS, the IT department. And this is really easy inside the facilities. All of the workstations that are in our facility and the laptops and computers on wheels are on our secure network for that very reason. However, if you leave the facility and you don't log in using a VPN or the private network, and you use something like LogMeIn or one of the other various programs that's set up to do that, you're no longer on a secure network. And if you use your home computer, if you take PHI on, say, a zip drive or a thumb drive, and you take it home and pull it up on your home computer, that is not on a secure network, so it can actually be hacked fairly easily. And do not engage in risky practices. This seems a little bit common sense. If you're going to surf the internet, I understand that people do on occasion. If you're going to surf the internet, don't click on links that you don't know the outcome. You don't know if they're fishy or anything like that. And then do not open attachments to email unless from a trusted source. Now, this becomes very difficult currently because they have this thing called spear phishing, where facilities are getting emails. People in the facility are getting an email that looks suspiciously real. So they would come from the CEO, CFO, anything like that, and telling you to follow some instructions and either send some money someplace or engage in a link to sign the facility up for something. And once that happens, once you engage in that link, they can get into our server. And at that point, they have access to all of our information. Once they do that, they use something called ransomware, where they sequester our information and then tell us, hey, we have your information. We can dump it on the public internet, and then tell the federal government that it's on the public internet, and you can be fined $3 million up to, who knows, $30 million. Or you can pay us $600,000 right now, and we'll give you the information back, and no one needs to be the wiser for it. And facilities are actually paying this because it ends up being less damage from either monetary reasons or from PR, that they just pay this out and then get their information back. And we don't want to unnecessarily print or copy PHI. This isn't as much for us, but there are facilities that still use paper charting in many areas, and so this becomes very difficult for them. When faxing PHI, we want to make sure we're using a cover page so people know how many pages are going to be transmitted to them, and they don't leave one of those pages sitting on the fax machine. That's actually one of the main reasons how breaches and improper disclosures happen with faxing. Somebody will take the 4 of the 5 pages and leave the 5th page and then send it on to another location just on accident. For the emails, if it's an internal email to one of our hospital emails, you're going to be just fine. Those are all on a secure email server. However, if you're sending exterior, we want to make sure we send secure. Rich Tyler sent out an instruction email, so make sure you did find that and follow that as well on sending secure. And this goes for any outside email that we're sending PHI to. And if somebody has a hospital email but is requesting you to send it to a Yahoo or Gmail or Hotmail account, just tell them you cannot do that. We're going to send it to the hospital email if it does exist, and if not, then send secure to those outside emails. If you're going to dispose of information in your PHI, make sure you use the shred bins that are provided around the facility. If there's a piece of electronic media like thumb drives or a disk, if you're not sure how to dispose of those, contact the help desk or the IS department, and they can give you some more information. And really, the last thing you could do is just be the eyes on the ground. Make sure that you report any suspicious activity to your supervisor, your director, myself, the director of compliance and risk management, Amber Fisk, the director of human resources, Rich Tyler, the director of IS, the information services department. And it really is any suspicious activity. We want to look into these things to make sure that we're not breaching information. So we're going to get into some special cases that we deal with on a daily basis in MHSC, and the first is a personal representative. Now, these are individuals that are designated by patients to receive just the information the exact same way that patients receive it. It can be done in an official manner, like a power of attorney. It can be done in an unofficial manner, where the patient just tells you they want that person to be their representative, or they just say that that person can receive all the information. Any of those designations would constitute a personal representative. And for HIPAA purposes, those personal representatives are basically treated as a patient, and they get to receive every bit of information that the patient receives. Now, there are times when we're not required to treat the personal representative as a patient, and these include if the minor has authority to consent to care, like if they're an emancipated minor, if the minor obtains care at the direction of the court by a guardian ad litem or other court-appointed guardian. This doesn't have to be a foster parent or a grandparent. That's the legal guardian. It can be just someone that picks up the patient from their foster house and takes them to receive care at the clinic. They're not necessarily that engaged in the care of the patient. If the parent agrees that the provider may have a confidential relationship. And then the last one, and this is important, if the provider feels like that, like treating the personal representative as the patient as far as HIPAA is concerned, would be a detriment to the patient. And the last two was the example came up in the training that if it's a teenager and you're asking about something like sexual history and drug use, it's probably in the best interest of the physician or anyone providing care to ask the parent to leave the room just so you can get some honest answers from the patient. So we may deny access to these personal representatives as well in a couple of cases. The first is if the personal representative tries to access those records after the encounter is over, we can deny that access, and we should. If it's anything behavioral health or psychotherapy notes, any of those, if the patient says that they don't want that personal representative to get the piece of information, we have to comply with that. If there is an anticipated civil, criminal, or administrative action or proceeding, this becomes incredibly important in cases like abuse and neglect, SANE cases, any types of those things, DFS, the Department of Family Services cases, where those records actually become separate and distinct from the medical record anyway, and they would have to be subpoenaed specifically in a court of law. And at the end, again, if the licensed provider has determined that access is going to be a detriment to the patient, they can deny access to that personal representative. Now, family and friends, the easy way to explain this is if the patient consents to the family and friends getting the information or has an opportunity to object and does not, we can give the family and friends as much information as the patient gives us access to. We do want to limit the disclosure to the scope of the person's involvement, and an example was brought up of a teen picking a parent up after a surgical procedure. You probably don't want to go into literally everything before and during the procedure about what took place during the procedure, why that procedure had happened, and all of the steps in the procedure, but you do want to tell that teen what to expect with the patient in the next 5 to 12 hours during recovery. You do want to tell them how to be a proper caregiver after the fact so that they can actually maintain the safety of that patient. And this does apply to disclosures after the patient is deceased. Another special case that we deal with on a daily basis is leaving messages. And this is allowed under the provisions of HIPAA. Those patients have given us that number to receive official correspondence from our facility, and so we can leave a message on those voicemails of those patients. And you would want to apply the minimum necessary rule on these. You wouldn't want to say, we're confirming your appointment tomorrow in the urology clinic for your enlarged prostate. We're going to discuss your enlarged prostate. You be sure to prepare for a conversation regarding your enlarged prostate and probably an exam of that prostate. That'd be ridiculous first, but also we couldn't do that. We can actually just say, we're confirming your appointment tomorrow at this time. Please give us a call if you have any questions or you can't make it to your appointment, something along those lines. And this also applies to a wife or spouse or someone in the household receiving those phone calls and not leaving a message. So you can tell that person on the other line the exact same rhetoric, basically, that you're just trying to confirm an appointment, have the patient call if they have any questions. And again, you would want to apply the minimum necessary rule and not give them all of that information as well. The next set of slides goes into why you should comply with this beyond because it's just right for the patient. And we're going to start with internally at MHSC. As far as HIPAA is concerned, we as a facility that houses PHI are required to investigate every possible breach or improper disclosure that is reported to us. Now, in the process of that, if we find that there is a person that is related to that breach or that disclosure, or a person did that disclosure or breach, we are required as a facility to reply to that, to respond in kind to that breach and disclosure. But with that, there are a lot of mitigating factors that we take into account, and we try to be as consistent as possible with those, because these corrective actions can go from just re-education up to and including termination with these. So many factors go into our decision, and first is intent. Is it malicious versus is it an accident, basically? If you get caught and you say to us, yeah, I was going to take all this information and sell it on the black market and try and pay off my house so I can leave my job, that's obviously intent and something that we can terminate for, and we probably should terminate for if we're doing what's right as far as the provisions of HIPAA. Self-reporting is important for many factors. Not only is it just the right thing to do, but if you report to us that there's something that you may have done based on a HIPAA breach or something, we can get to it early enough that we can limit the impact of that disclosure. We can bring something back from a breach and just make it an incidental disclosure where we don't have to call the patient and we don't have to have a corrective action with you. We can just do education on those. And then if you self-report and we still find a breach, that we do factor that very favorably. The process surrounding the disclosure, it explains if there is something wrong with our computer system or another process and you just happen to be the one that found it, if you happen to be the one that clicked a button, and at that point in time we sent a lot of information to another facility, but it was a system related error, we wouldn't be doing you or our facility or the patients a service if we just gave you a corrective action. We have to, as a facility, respond by fixing that process. And in the case, as far as HIPAA is concerned, they would tell us that we weren't complying with HIPAA if we just gave you a corrective action or terminated that person. We would have to fix the process. An amount and type of PHI also a factor in, and it's kind of common sense. 50 records is worse than one record. 50 visits for one patient is worse than one visit. If it's a behavioral health record, it's much worse than a regular medical record, and so on from there. The Office of Civil Rights can go after civil penalties to facilities and individuals, and they do so based on category of violation or category of breach. And the category 1 is where your accidental breaches fall into. This is that we were unaware of it and we've taken a reasonable amount of care otherwise in this process, and this is just a one-time breach kind of thing. Category 2 is more serious, and it goes into that we should have caught it given the systems that we have in our facility and did not do so. And we are either trying to fix it or are not trying to fix it given that we found an issue that we couldn't afford to fix at the time, or any one of those things. Category 3 establishes the idea of willful neglect, and this is that there is a process or a hole and we've just decided not to fix it. The process itself is created in a way where someone just doesn't follow that process and decides to do something of their own volition, and there's a breach. And then category 4 is if that type of willful neglect is around the whole facility. So we have done nothing to establish an idea for what HIPAA should be inside of a facility, what we can do to protect PHI, any of those things. Category 4 is obviously the most serious. But you see on here that these categories, like the category 4 has a minimum fine of $50,000 per violation. Category 3, where that willful neglect comes in, is $10,000 minimum fine per violation. And these can have a maximum fine of $1.5 million per violation category per year. And then the federal attorney generals can establish more of a fine, can tack on more fines during the court case. Because HIPAA is a federal law, these are all tried in a federal court. On this slide, you can just see some of the civil penalties that have been levied to facilities in just the last year and a half. So this one here, the 5 breaches, they were 5 patients, not 5 large breaches. They added up to a $3.5 million settlement. This one here is where the facility actually, this company shut down, so they liquidated, but they didn't keep the securities up in their information clearinghouse, and it was hacked and the information was stolen. So they had to pay $100,000 after the fact because they didn't keep up their securities. And one of my favorites is right down here, where it's $2.5 million, and it shows that the facility did not understand the HIPAA requirements. So these are real penalties that have been handed out in the last year and a half. On top of the civil penalties, there can also be criminal penalties that are handed out in these cases as well. And they do it by tiers, which is similar to the categories in the civil penalties. But you see the tier 1 there is reasonable cause or no knowledge of violation. So this is your accidental breaches. So if you had a piece of paper in your back pocket that fell out in a public area, and that paper has enough information on it where somebody could steal a patient's identity, and once that patient's identity is stolen, whoever steals it empties their bank account and their retirement account, and then that patient loses their house because they don't have any money along those lines, and that patient's life is damaged or destroyed going forward, then they could come back to whomever is the person that had that piece of paper in their back pocket and dropped it for civil or for criminal penalties. And you, just for that, just an accident, you can have 1 year in jail for that. Tier 2, it's obtaining PHI under false pretenses. So you can see here, this is where the clear criminal intent starts coming in, and that's up to 5 years in jail. And tier 3 is obtaining PHI for personal gain or malicious intent. And this is not just obtaining, it's when you have it, what do you do with it? If you use it for personal gain or malicious intent, that can also be a tier 3 criminal violation. And all of these are decided by a judge in federal court. Now we're going to go into some cases that have happened either at MHSC or could happen at MHSC given some of the systems that we have. So the first one is 2 patients are being discharged. Nurse grabs a discharge education for 2 patients and hands it to one of the patients. The patient who received the additional discharge education brings the information back in the facility. So is this a permitted disclosure? And the answer to this is no, it's not a permitted disclosure. This is absolutely a breach. And what category would this fall into in the OCR classifications? And most people would probably say category 1, the accidental release, the accidental breach. However, this is a category 3 because there is a willful neglect in the process. They would say that the process of grabbing the discharge education off of the printer and then looking at the discharge education to make sure that there is just the one patient is a reasonable amount of time, that not following that is willful neglect. And this would cover, this has, again, category 3 had a minimum fine of $10,000 per case. For case number 2 here, PHI is being sent to an establishing provider within a hospital. One number is hand typed incorrectly and the PHI is faxed to another location within the same hospital. Think of the clinic and the hospital in MHSC's organization. And a follow-up fax was sent explaining the error and the information was destroyed on site. Is this a permitted disclosure? Now, many in the training were shaking their heads saying, no, this was not a permitted disclosure. However, yes, it is. This classifies as an incidental disclosure. And these are the cases that we got a hold of early and minimized the impact because we knew ahead of time. Also, if the facility is within the same organization as your destination facility and they would reasonably receive PHI from you at a given time, any other given time, then it is an incidental disclosure. And then on top of that, if you can confirm that the information was destroyed and was not perused by anyone there, again, at that point, it would be classified as an incidental disclosure. So MHSC contracts with a new patient experience contractor that will be receiving patient names, encounter dates, and contact information to reach out to patients. The facility has an agreement that references a BAA but does not have a BAA prepared for a vendor. So the BAA is just a one-page agreement saying that the two facilities are going to comply with HIPAA regulations, and then there's an admonition clause in there where if they violate the HIPAA rights, it's their liability to do so, and then if we do it, it's our liability, that kind of thing. So is this a permitted disclosure? The answer to this question is no. This is not a permitted disclosure. However, in this case specifically, the company is just calling those patients and asking them how they felt about the care they received at our facility. They're doing what we're paying them for. They're not taking that information and selling it to the highest bidder or anything like that. They're doing exactly what we're paying them for. So when we look at these types of things, in general, they're not doing anything wrong. They're doing exactly what they're hired to do. And the facilities might not be as gung-ho for these business associate agreements as we have to be, because it's not their information. It's actually our information, and therefore right now they're operating under our liability, and anything that happens at their facility, it reflects on the hospital's liability. So then again, what category would this fall under for the OCR category? And a lot of people didn't really know where to answer this in the trainings. However, this is a Category 4 violation. And what the Office of Civil Rights is doing is saying that any contract that should have a BAA and does not at these facilities, they're getting an immediate $30,000 fine per agreement or per vendor. And it could be multiple $30,000 if there's multiple agreements with the same vendor. In this case, too, again, there's nothing bad that's happened to these patients' information. They've just not had that one-page agreement between the two facilities. So even in those cases, it's an immediate $30,000 fine. The last one here, staff member becomes privy to embarrassing PHI of patient who is married to a former spouse. The staff member accesses this information appropriately as a function of their employment. The staff member chooses to voluntarily end their employment and move to another job within the community. The former staff member then uses the appropriately obtained PHI to negatively affect custody hearings with patients and former spouse. So the question, is this a permitted disclosure? I think everyone agrees that this is not a permitted disclosure. However, is the hospital liable for this breach? Many people said yes in the training. But the answer is no, because this person obtained the PHI appropriately as a function of their job at MHSC. And there was no reason for us to question what they were accessing at that point in time. It was just a normal function, like a nurse getting patient nursing information while they were working. And when we look at this case, what other penalties could be assessed in this situation? There are probably many that people go for, but really it's a tier 3 criminal action, because this person, even though they obtained it normally, used that information for personal gain or malicious intent. And this case was actually prosecuted. This was a real case. If you happen to have any questions about any information that you see on this presentation or any other questions regarding HIPAA or other compliance issues, you're more than welcome to contact me. I've given you my email, my office phone, and my cell phone on here. You're more than welcome to contact any of those with any questions whatsoever. We want to establish a good understanding of what HIPAA means at MHSC. And with that, I want to thank you all for listening to the presentation, and we hope you have a good day.